Good evening and welcome to our seminar. I'm Dr. Seeger, and this is our Bariatric Medical Institute of Texas, or BMI seminar. Thanks for coming out. I know it's a cold and chilly Thursday night, and we appreciate you spending some time with us. I'm going to start by introducing our practice, and that's going to begin by introducing my partner. This is Dr. Treve Duperior. He's a fellowship-trained bariatric surgeon, consistently one of the top docs in San Antonio. He's also a Center of Excellence surgeon, and he's the medical director of bariatric surgery here at the Foundation Bariatric Hospital. That slightly better looking gentleman is yours truly. Some similar qualifications, also fellowship trained, also in the top doc group. I started a fellowship training program here to train other doctors. So we take doctors from all across the world that apply for our program, and we show them how to do some of these things. And it's important for you to know because you're going to have your surgery done by people who do a lot of training of other places and other programs, so that's nice. Rather than going to someone who learned from us, you're going to actually go to the teachers to have your surgery done. I'm also a national proctor for Realize Band, so I travel around the country helping other surgeons learn how to set up a program and actually learn how to do band surgery. I'm also clinical assistant professor of surgery at University of Texas Health Science Center. This is Dr. Jennifer Seeger, who is a board-certified family practice doctor. She's the medical director of our BMI weight management program and also the pre- and post-operative clinic. She's also my wife, and she does a lot of medical weight management and also helps out with getting our surgery patients ready for surgery. As you learn through the process tonight and as the days go by, a lot of the things that stand between you right now in the operating room are insurance regulations and things and hoops that they have you jump through. And Dr. Jenny is really good at helping us get through some of those hoops. So you may actually be seeing her along with us as we get you ready for your operation. This is Melinda. She is our physician assistant. We're very lucky to have her. She's been in our practice since 2010, joining us from a practice in Houston. She has over 4 years of experience with weight loss surgery patients, and we'll be delighted to introduce you to her. A little bit more about our practice. Both of our surgeons are fellowship trained. We have the only training program to teach other surgeons how to do these operations in all of South Texas. We have a special way to manage band patients using fluoroscopy or x-ray, and I'll show you that momentarily. We do all the different types of weight loss surgery, so everybody's needs are different. You can't expect that the person sitting next to you needs the exact same tool or treatment that you do, and for that reason it's important to know that you have a bunch of different options. Many practices will try to pigeonhole a patient and say, no, you need to have this operation, this is the only one that you should have. And that's just not true, and that's why we offer all of them. We're also a center of excellence as deemed by the American Society for Metabolic and Bariatric Surgery. So the talk. Every talk begins with a definition, right? So here is the definition of morbid obesity. It's extra weight that causes or makes worse medical problem, right? It's making you sick. And that's the definition in words. We also have a definition in numbers. This is a calculation we do to figure this out using the metric system. So we take your height and your weight, and we figure out a number called your BMI, or your body mass index. And I love this cartoon because it's so appropriate. You know, your weight is just perfect. You're just 11 feet too short, right? So it means something different for a patient to weigh, a 7-foot tall patient to weigh 300 pounds than it does for a 5-foot tall patient to weigh 300 pounds. And that's what this calculation takes into account. Here's an example of one of our patients, Terry, with a pre-op BMI over 50 and post-op BMI of 32. What do those numbers mean? Well, they're ranges, right? 20 to 25 is considered an ideal BMI. After 30, we start to see increasing medical problems or negative health effects as a result of your weight. After 35, that's when we know it's time to start thinking about surgery. And there's a number of reasons for that, but the number one reason is that the medical problems are starting to sneak into your life and you need to do something to get healthy. 40 BMI is considered that about 100 pounds overweight. And after 60 on the BMI chart, we start to see increasing risks for surgical procedures. And that's any kind of procedure. If you're going to have surgery on your big toe your risks of anesthesia will be higher because our patients have problems with breathing and circulation when they get a BMI over 60. So that's an important number for us. Weight-related medical problems, I told you that weight can make you sick. Some of these problems may look familiar. Sleep apnea, diabetes, high blood pressure, knee pain, back pain, joint pain, acid reflux. And actually we know now that obesity is associated with increased risks of cancer. And so this is something that's very important for us to try to treat to prevent these diseases or eliminate them should you already have them. And these are all very important medical problems, but some of the things that our patients find most rewarding about surgery is the social aspects, the things that they're able to do that they couldn't do before, the things that they wanted to do that they couldn't. Riding on a roller coaster, getting down on the ground and playing with grandkids. There's lots of things in your life that doors will open up for you when you become more healthy and your weight reduces. So treatment of morbid obesity is about making you better in better physical condition, better health, and preventing some of those medical problems that we just talked about. So what can you do? There's tons of stuff out there, right? Commercial diet programs, drug therapy, exercise, cognitive therapy, hypnosis. Well, who's been on a diet? All right, everybody. You've all been on a diet. And what happens when you go on a diet? You lose weight. And then what happens? You gain it back. So why? Okay, so this is this drawing here explains that. So when you're overweight and you go on a diet, you decrease the amount of calories that you're taking in, so you lose weight, right? Your body also, it notices that. It's like, hey, I'm not getting the same calories that I once was. So it slows down the metabolism. It's called the famine response. So you'll lose weight also from lean muscle and bone if you're not exercising during that time. It slows down the metabolic rate, or the rate at which you burn calories. When you turn that down, then the body says, okay, well, I need to start storing things because this might be a period where I'm not going to get food, so I need to shelter and store calories. Then you get sick of your diet, or you fall off for some reason, or what just happened, right? The holidays, right? Really hard to stick on a diet during the holidays, and for some reason you stop the diet. Well, your metabolic rate is still low, but now you're eating again like you were before your diet, and so you gain weight back, the weight that you'd lost, and then some, right? So that process happens over and over again, and it leads to that yo-yo phenomenon where you lose weight, you gain weight, you lose weight, you gain weight, and slowly over time you gain a little bit more than you lose, because as you age, we all know our metabolism slows down. Nobody burns calories today like you did when you were 18. It's just not the way it works. And so over and over again this happens. So we've studied this very carefully and scientifically, and it turns out that 98% of patients who have a BMI over 35 will have a bounce back. If you lose that weight, you will gain it back, right? So 98% of patients will fail without doing something surgical to prevent weight regain or to lose the weight that they need to. Now you guys know this gentleman here, right? Jared. Jared is able to eat the Subway sandwiches and keep his weight off. We want to be sure that you're not one of those 2% of people like Jared who can do that. So if we haven't tried adequately, then we're going to put you in a program and make that go. But if you have and you're confident, then we're going to take the next step. So surgery needs to be considered after you know that you're not one of those 2% of people who can treat it medically. These are some of the ladies that you'll meet in our office. Here are the 3 surgical treatment options. We're going to spend time talking about each one, but just a general introduction here. On the left is the gastric bypass. In the middle is the gastric sleeve. And on the right is the adjustable band or lap band. We're going to start by talking about the gastric bypass. The gastric bypass is the oldest operation that we do, meaning it's been around the longest. It's stood the test of time. It's done in 2 parts. There's a restrictive part and a malabsorptive part. So the first part of the operation involves restricting the amount that you eat. And this is done by making the stomach into a very small pouch. So the stomach is divided into 2 parts. This upper part we'll call the pouch. It's about the size of your thumb. It's very small, right? It'll hold less than 15 cc's, which is about ½ an ounce of fluid. The second part is involving the intestine. So once we've separated the stomach, we bring the intestine up and connect it to that pouch. We make a second connection between the intestines and themselves, and I have a cartoon of this that I'll show you in a minute to help it make more sense. So the two ways that it works is by helping you eat less, number one, and by helping you not absorb everything that you eat, number two, okay? The lower part of the stomach, or the part that's bypassed, still remains healthy and stays in place and continues to provide your body with hormones and other things that will help you absorb food and nutrients downstream. It also has an added effect of something called dumping syndrome. That sounds like a terrible thing. What that is a reaction that your body has to something that's bad for you, like a sugary sweets, right? Anything with refined sugar in it will make you feel bad if you have this operation. It's called dumping syndrome. Some people feel crampy pain, you might sweat, you might have some diarrhea or nausea, vomiting. Generally it's a bad feeling, and everybody's is a little bit different. If you know that you're a person that is really inclined to sweets, and sweets are part of the problem, then this is really something to consider, because this operation will help you with that. All right? This is the only operation that gives patients dumping syndrome. Now here's a cartoon of the gastric bypass.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. This smaller stomach pouch restricts the amount of food that can be eaten before feeling full. The small intestine is separated into two sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. Bypassing a portion of the small intestine decreases the absorption of calories and nutrients. The upper portion of the small intestine is reconnected to the lower portion of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested.
Here's a picture of our medical assistants. You'll get to meet them as well. The next operation that I'm going to talk about is the lap band, or the adjustable band. This is a silastic, or a special type of plastic. It's a belt, just like you might wear around your pants, except for this belt goes around the top part of your stomach. And it's unique in that the inner lining of this belt is a balloon. So when we place it around the top part of the stomach and buckle it into place, there'll be a balloon in contact with your stomach. Now that balloon is connected to a piece of tubing, right? And the tubing is then connected to a little reservoir, or a port. We call it the port. Now this port will sit underneath your skin. You won't see it. There won't be anything hanging out of you, but it'll be under the skin. And I'm going to pass around a few of these as we talk so that you'll be able to understand. But the way that it works is that you eat food and it goes into the top part of your stomach, above the band in this area here. The band will hold the food in place and make you feel full with a very small amount of food. Eventually that food will move through the band into the regular normal stomach and pass through the digestive tract normally. Now one of these bands has a syringe attached to it, and some of them have different types of ports, so you'll see different versions of the band. But the one with the syringe is used to show you how the balloon works. So over time, we'll tighten that balloon around your stomach and it'll tighten it up. So more and more fluid, and then you'll eat less and less. You'll lose more and more weight, right? So over time, this is adjusted. Now you can't have all the fluid put in right off the bat because you won't be able to tolerate it. So it's a process, so we adjust over time. You will also not have a syringe hanging out of the side of you when you wake up. This is just to demonstrate to you how it works. So I'll pass that around. So the band is about 9 years old, 10 years old now in the United States. It is considered a permanent operation, although it's reversible. So what do I mean by that? Well, reversible means we can take the band off. Permanent means if we take it off, you will probably gain your weight back. So we want you to keep it in place forever, right? Even though if we needed to take it off, it's very easy to remove. So again, we have a cartoon of how it's placed. So this is another surgery.
To gain access to the abdominal cavity, Small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are placed through the trocars into the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The Realize band is introduced to the abdomen through a trocar. The Realize band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the Realize band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the Realize injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The Realize band does not alter your digestive function. Food consumed passes through the digestive tract in the normal route. Your surgeon may tighten the Realize band by injecting saline into the injection port. As the saline is introduced to the Realize injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch restricts the amount of food you can eat before feeling full.
The band will be adjusted over time to tighten the stomach to your specifications, and we do that at BMI a little bit differently than other practices using a special x-ray machine. So here is our fluoro room, or where we do our adjustments, and what happens is a patient will come into the room. They'll stand on this table. We'll take a picture of their band and we'll place a small needle into that port under their skin. We do that under direct visualization so we can see what's happening with this machine. Why is that important to you? Because almost all other practices in town and in all of South Texas will do it by feel. So they have you lay down and then they just start poking until they get it in there. And they can get it, but you know, it's a lot of poking sometimes. Well, we can see where it's going, we place it in very easily, and then we give you a tailored adjustment to what your needs are. Again, comparing that to another practice, they use a cookbook, meaning if you're 6 months out from surgery, they might give you 1 cc of fluid no matter what. Well, we can see what your needs are based on your band. We can watch it working. We'll give you something to drink like you'll see in this film, and this will help you understand it a little bit better. Today we're going to be doing I'm Dr. Mickey Seeger with Bariatric Medical Institute of Texas, and today we're going to be doing an adjustment of a laparoscopic adjustable gastric band. We've prepared our equipment here. We have a simple syringe and some tubing with a specialized tuber needle that's a non-coring needle, so it does not damage the band port. And we have our patient in our fluoroscopy room. We do all of our adjustments under fluoroscopy. Helps us to do more accurate fills and give the patients exactly what they need. So we're going to begin by palpating the port, and if you'll just remain still and just turn flat straight ahead, that's perfect. And we'll take a couple pictures and we can see the port on the screen there. So I'm going to make some adjustments to get my needle into place. And we can see it on the screen. You're going to feel a little bit of a poke here as the needle touches your skin, ma'am. There it is. And a little pressure as we access the port. We go straight into the port, and we should be in at this time. And we have good access, so now we're going to move our fluoroscopy machine up and take a picture of the actual band itself. On the screen you saw before, this was the port, and the access was done. We're going to take another picture, a little bit higher. And you can see in this location, this is our band. It sits at a nice 45-degree angle with the spine. Also on this picture are some clips from your bra, and then you can see the tubing coming off the band right now. So we're going to give you a little something to drink, and you go ahead and take a small sip of that, and we will take some pictures before we do the adjustment. In this picture, you'll see the contrast coming down into the esophagus where it's sitting now, and then into the pouch, and slowly moving towards the band. Can you take another drink for me, a little bit more? And there it moves fairly quickly through the band. So we're going to make an adjustment to see if we can't tighten that up a little bit. I'm adding 1 cc there, and we're going to try and see what it looks like with that. So about the same size of a sip this time, and we're going to do that same procedure. So again, there it is in the bottom of the esophagus, entering the pouch now, and slowly moving through the band, but not much. Most of it went back up. So you see that's too tight. There was a little bit of reflux there. So we need to remove a little bit of that fluid. What we're looking for is to slow the flow of contrast down. But not to stop it. So take one more drink for me. I bet that was loud in your ear. Sorry. And that's a perfect adjustment. Do you see how slow that it moves through there? Tiny little bit of reflux at the end, so I may back off just a little bit, but that's what we're looking for, is that level of adjustment, where it slows that fluid down, but doesn't stop it. Let's do one more time and see if we can get that perfect image that we're looking for. Okay, again, in the esophagus, moving into the pouch and through the band channel with an excellent slowdown, but no stoppage of the contrast. So that's exactly what we're looking for. That's a perfect fill. An adjustment for a patient based on what their needs are. So the cookbook was too tight. If you went to another practice and had your adjustment there, you would be back in about an hour because you would be vomiting. Well, at our practice, we're going to see that, and we're going to give you just the right amount so you don't have to be too tight. We make you the right level at each adjustment. Now that doesn't mean that you can't swell or become too tight, and it doesn't mean that we never have a patient that you have to loosen a little bit. It just is a lot more rare when we see how to do it correctly as opposed to guess. All right? Now, I'm going to move on to the next operation, which is the sleeve, called the gastric sleeve, also known as the sleeve gastrectomy. This is the newest of the surgeries. About 4- and 5-year-old data now we have on this operation. This operation is done by removing part of the stomach, right? So the stomach is normally shaped like a football, and we remove this part over here, so now it's shaped like a skinny tube or a sleeve. That sleeve will hold maybe 3 or 4 ounces of fluid, not very much. So number one way that that works is by making you eat less. It turns out that this part of the stomach over here is responsible for making a hormone called ghrelin. That hormone is a hunger hormone, right? And we remove the factory for that hunger hormone. It takes away a lot of patients' appetite, right? So this is the only operation that removes that ghrelin center. It's a hybrid between the gastric bypass and the band in certain ways, if you want to think about it. It's like the bypass because it's only your tissue, right? We haven't added a man-made device in there. We're still just using your tissue. And it's like the band because it's only working on the stomach. There's no intestinal involvement. A lot of patients, this is appealing to them because it does preserve the natural order of things. When you eat something, it still goes through the same path that it always did. It's just that your stomach is smaller. And it also doesn't involve implanting a man-made device. And so that's appealing to a lot of people, the patients that choose this operation. Now it does have a long staple line, right? So there's, talk about later with that. It's not adjustable like the band, but it is very restrictive, even more so than the band. And this is obviously permanent since we're removing part of the stomach. A little bit more about this we've been doing since 2006. Our weight loss results are similar, a little bit less weight loss than bypass, and I'll have some slides on this in a minute. It could be converted into a bypass. In fact, that's how it was initially designed, to be made as a 2-stage procedure, initially thought of to work with really high BMI patients. This operation was done as stage 1, and then we'd go back and make a pouch later and do the rest of it. What we learned was that our weight loss was almost always adequate with this operation alone. Now this operation is not covered by all insurances yet. Almost all of them have picked it up. The exceptions to that are Medicare, which is currently not covering this operation, and Humana. So Humana we're hoping will pick it up in 2011, but we have not heard anything about it yet. All the other ones, for the most part, are recognizing it. There are some exceptions, but for the most part, it's being covered.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. Surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes to help break down the food into a more simple form, so that it can be more easily digested and absorbed once in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 to 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. The newly created gastric sleeve is able to hold approximately 1/10 of what the stomach was able to hold before. This smaller stomach sleeve restricts the amount of food you can eat before feeling full. The bile and pancreatic fluids from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments necessary for the sleeve gastrectomy.
Okay, gastric banding and bypass sleeve. This is a comparison slide talking about some general stuff about surgery, operative time, etc. So both of them are done laparoscopically like you saw in the cartoons. That means small incisions in a camera. You usually have one more incision for a sleeve or a bypass than you do for a band. And those operations take a little bit longer than a band. A band might take 30 minutes, a bypass may take an hour, hour and a half. Most band patients can go home the same day. The exception to that is if you have a medical problem that makes us want to watch you overnight, or if your insurance requires that. One of the insurances that requires us to spend the night is Medicare. Patients that have a sleeve or a bypass, usually 2 to 3 nights in the hospital, right? Usually 2. Return to work after banding is very quick, right? About a week out is what most people take. With a bypass, it's usually longer, more like 6 weeks, and with a sleeve, 2 to 3 weeks. So a little variability there. Follow-up visits are more frequent with banding, and the reason for that is there's a need for adjustments. We need to tighten your band with time. You will get used to the level of tightness after about 3 or 4 weeks, and then we need to put more fluid in. So expect to come in every month as we're on that weight loss slide, losing that weight over the first year. We like to see people monthly to make sure that we're doing our job to get the right amount of fluid in that band. So there's more follow-up visits with a band. Compare that to a bypass or a sleeve where they only require 4 to 5 follow-up visits in a year. Other differences, and this is a busy slide. Obviously, you remember a bypass, it's more complicated, right? So there's more stress on the body, and there's some more risks around the time of surgery. A band is simpler, less risks. Most people, like I said, go home the same day. And a sleeve is intermediate in terms of complexity and therefore intermediate in terms of risk. The band is sort of the granddaddy. We have 30 years of data, and the band is in the middle, about 10 years of data now, and the sleeve 4 and 5 years of data, so it's the baby operation. All of them work to control volume of food intake, right? The bypass is the only one that offers the malabsorption and the dumping syndrome, okay? Other comparisons, the weight loss is slightly different. So with sleeve and bypass, you lose weight very quickly, right? Within the first 9 to 12 months, most of the weight is lost. With a band, it's slower. So you might take 2 to 3 years to lose all the weight with a band. Compare that to the other two. There's also differences in the amount of weight that you might lose. With a bypass, we usually see about 70% of your extra weight being lost. So if you're 100 pounds overweight, you lose about 70 pounds on average. If you're 200 pounds, that's 140 pounds of weight loss. Sleeve is very close to that. 65% is about what we're seeing in our practice. And a band is between 40 and 50%, so it's somewhat less. Now, if you're only 80 pounds overweight, those percentages don't add up to that much, maybe 10 or 15 pound difference. But if you're 200 pounds overweight, it makes a big difference. Now, when you come to the office and you sit down with myself or Dr. Duperior, we're going to tell you, look, this is your excess weight. We expect that you're going to lose this much weight with this operation, this much weight with that operation, and help you make that comparison so that you can make the decision that's right for you. Decreased absorption of minerals happens in bypass, although decreased intake happens with all the procedures, so everybody needs to take some supplements. Most of the protein, most of the minerals that you get in your diet, they come from the food that you eat, right? So when you take that food intake and you decrease it substantially, you'll need to take some vitamins to get the right amount in your diet. Again, a bypass does not have any hardware left behind. Neither does a sleeve, but a band is a functioning piece of hardware, and it's something that has to be managed over time. A bypass is possible to be reversed, although it's very difficult and risky. A sleeve is not reversible, however, it's convertible to a bypass. And a band obviously is reversible, but we don't want patients to choose their operation based on reversibility, because that'll put you back in that yo-yo diet cycle and you'll gain your weight back. Here are some important ladies for you, your patient advocates. They're going to help you get from here to the operating room, helping you navigate the insurance pathways. So a little bit of general statements about surgery. Surgery is a really amazing and powerful tool, and with whatever operation you choose, you're going to lose a massive amount of weight. But you have to remember one thing, this is a tool and it is not a cure for obesity, right? Obesity is caused by multiple things. It's genetic, it's environmental, it has to do with your metabolic rate, it has to do with what medical problems you have, what medications you're taking, it has to do with cultural issues. No surgery is going to change the fact that your parents are who they are, your genetics are what they are, or the fact that there's Taco Cabana on every corner in our city, right? It's just the way it is. Those things will never change. So surgery is a powerful tool, but it doesn't change everything about the causes of obesity, right? So I want you to know that. It will work, but we need to engage it and use it as best we can. All right, the diet. After surgery, there's some specific rules. They're not many, but they're important. So how many of you guys have bought a diet book before or read one, right? Pretty much everybody's read a diet book. And it's usually pretty thick and has a lot of information in it. Well, this is my diet book, right? Our BMI diet book. It's short and sweet, and it's that way because I want you to be able to remember it very easily. So here it is. I'm going to spend a little time with it. 3 meals a day maximum. That means if you're not hungry and it's 12 o'clock and everyone's going off to eat, you don't have to eat, right? You eat when you're hungry, but don't snack between meals, okay? Eat small meals and take your time to do so, okay? This is really important, and I'm going to explain to you why. The nerves from your stomach that communicate to your brain are slow, different than other nerves. You know, if I went and hit your finger with a hammer, when would you know that I did that? Right away, right? But you remember Thanksgiving? It wasn't that long ago. When did you know that you'd had too much to eat? Was it when you put that bite in that did it? Or is it about 20 minutes later, right? When you're like, I shouldn't have had that second piece of whatever, right? You guys know what I'm talking about, right? So why is that? So the innervation doesn't communicate rapidly with your brain. It takes time to send that message. Why is that important to you? Well, because we're about to make your stomach this big, and you could fill it up with, you know, a mouthful, right? So we need to figure that out so that you take your time to eat that meal slowly. We want you to feel the signal of satisfied. We don't want you to feel the signal of pain or overstuffed, right? So you'll figure that out after your surgery, but it's really important for you to know that. Now, we also like patients to separate drinking from their meals. The reason for that is that if you wash it down, then your pouch will be empty again and you'll be able to eat again sooner, right? So we want that food to stay in your pouch for an hour. Send those signals to your brain, make you feel good and satisfied, then you have something to drink and everything's fine. But if you drink too soon, the food might go through and then your pouch is empty and you might get hungry again before it's time. So we don't want to do that. Lastly, we just took your 15-gallon gas tank and shrank it down to the size of a Dixie cup, okay? And you've got to get fuel for your whole day, right, with a very small meal. So we have to put the good gas in there. We can't use the cheap gas. We have to use the good stuff. Protein and vegetables must go in first. That's the good gas. Doesn't mean you can't ever have a carbohydrate again. It just means that needs to go in first, because that's the stuff that's going to give you the fuel for the day. You guys know now, what kind of energy does carbohydrate give you? Right? Really quick burst. But protein will give you sustained energy. So putting protein in is very, very important to us. All right? We talked about drinking. So we want you to avoid drinking for 1 hour after your meals. Physical activity. When you have your surgery, and we do it laparoscopically with those little incisions, we do not put restrictions on your activity. We want you up and at 'em. In fact, as soon as you wake up from your surgery and you open up an eye, there's going to be a nurse standing there waiting to get you out of bed, right? And you're going to think she's the devil, but you need to get up and do it, because it's really important to help you recover. The quicker you walk, the better you'll feel, and that's also true of exercise. The more you do, the better you'll feel. When you're losing massive amounts of weight, if you're not doing exercise, your body is going to say, okay, break down everything we got, which is muscle, bone, and fat. We don't want to break down muscle and bone, really, but we do want to break down fat. So you have to send your body the message that says, please keep the muscle and bone, break down the fat. Do you know how to send that message to your body? You exercise. It doesn't take much, but you do need to do it. It's really important. All right? We're going to have everybody involved with a program even before surgery, and this is very useful to continue afterwards and important. Now, there are lots of psychological issues that go along with losing a bunch of weight. We want everybody to have handles on things that might trip them up. So, you know, you need to ask yourself, and we're going to have people help you, but we need to figure out if there's any food triggers that you have, you know, why you eat. If you eat for stress. Anybody eat for stress? Anybody eat when they're bored? Those are really, really common things. So no matter what surgery we do, it won't take away the fact that at some point in your life you're going to have some stress, and you will also be bored. So I want to know what you're going to do now that your stomach is this big and you can't eat when you're stressed or when you're bored. We have to have plans for these things, and we want to deal with them. We want to recognize them and deal with them, right? Is there a food addiction? Is there a particular food that you've established a relationship that we need to work on beforehand? We want to get all those things out before surgery so that there's no surprises. And lastly, a lot of folks will go into the surgery thinking that it might help them out with some relationship difficulties, right? If only I could get my leather jacket again, then Susie would love me once more. Well, it's not true. Susie doesn't care if you can wear your leather jacket or not. But we want to make sure everybody understands that. In fact, sometimes losing weight can put more stress on a relationship than was on it to begin with, right? Because jealousy issues can rise up. And we want to be very honest and frank about that, because the more stable support that you have going into this, the better you're going to do. So we want to acknowledge all these things as real issues and tackle them in advance. So the bottom line, what's been going on so far in your life, it's not getting you where you want to be, right? So much to the point where you're sitting here with me on Thursday night talking about doing something big. We want to do something to fix this problem once and for all, right? Now, I told you before, these are amazing tools, and they're going to help you lose a lot of weight. You need to learn how to use it as best as possible. The better you can harness that energy and use this tool, then the better long-term success you're going to have, right? And we're going to be very clear on the things that you need to do to be successful long-term. So here's the start of that. What commitment do we ask? We want you committed to living a healthier life, being healthier. And there's 3 parts to that initially. 1 is developing healthier eating habits. 2 is being more active. And 3 is the behavioral piece, so recognizing and dealing with those food issues. Taking supplements. This is necessary for everyone, so we want you to know in advance and be committed to it. We want to be committed to a lifetime follow-up. Who's had surgery before of any kind? All right, so what does the surgeon do? They come, they operate on you, they see you back in the clinic once, they slap you on the back, and they send you down the road. That is not this way with our practice, right? We are here to support you not only through the pre-op and the surgical period, but for the rest of your life. We want to see you forever. If you gain 5 pounds in 10 years, I want to know about it. We have ways to figure out exactly what your metabolic rate is and tell you, look, we need to change your diet in this way, and we need you to exercise to get your heart rate to 120 beats per minute 3 times a week for 30 minutes, and then you'll be at your target weight in 3 weeks, right? We have science to back that up. We want you to know that we're committed, all right? I have 5 kids, all under the age of 12, so I'm going to be working for a long time, okay? I'm going to be here, and I want you to know that I'm here for you. Dr. Dupiri and I will be here. Here's some pictures of some of our patients. This is a patient who had lap band surgery, Myra, before and after. Here's some expectations. So, do we expect people to get to 20 BMI? No. Do we have people that do? Absolutely. But most people with bypass will lose about 70% of their extra weight, 40 to 50% with a band, about 65% with the sleeve. Other outcomes of importance, some of you may be dealing with diabetes. If you do, this slide is really important. Bypass patients, 84% of patients that have diabetes and have a gastric bypass will go into remission or cure of their diabetes, and that means they're not taking any medicine, they have normal blood sugars, normal A1C. If you're diabetic, you know what that means. It's really impressive. You will leave the hospital, in most cases, done with diabetes after a gastric bypass surgery. It is amazing what happens, right? You don't have to lose any pounds. You walk out of there, and the fact that your stomach is now bypassed, there's some hormonal things that happen that give you better sugar control, and almost always patients go home on no medicine. It's a little bit different with sleeve surgery. 65% is the latest number. And with band patients, it's less than that. It's 48%, and it takes time with the band because there's no rerouting of the intestine. It takes time for your diabetes to go into remission. High blood pressure, massive improvements with all the operation or resolution. Sleep apnea, again, massive improvements or resolution with these operations. Hyperlipidemia, that means high cholesterol and triglycerides. Those are risk factors for heart attacks, strokes, and early death. Massive improvements with these surgeries. Also acid reflux, massive improvements. There are lots of other medical problems, but these are some of the most common ones. This has a powerful impact on your health, not just the number on the scale, but the number on your quality of life and the amount of medical problems that you're dealing with. This is a patient, Shirley, who had gastric bypass surgery before and after. Risks. I'm going to go through these. Risks of death is extremely low with these surgeries now. It is now approaching the level of gallbladder surgery, okay? So risks of death with a bypass is about 1 in 1,000. With a band, 1 in 10,000, all right? Sleeve will be somewhere in between. Very low. Other risks include not able to do these operations laparoscopically. So we used to make a big cut on everyone and go in there and do it. Nowadays, we hardly ever do that. Dr. Dupiri and I think we've had to do that once in the last 2 years on a patient. It's very uncommon. Almost always we're able to get it done with the little incisions. Other risks include general risks of surgery like bleeding or infection or damaging organs in the abdomen. Uncommon, but they're possible with any operation. Some people can form gallbladder stones after they have a massive weight loss. So we watch for this, and in some cases, we'll give you medicine to prevent you from forming gallbladder stones. Blood clots are important to us because all of our patients have circulation issues. Even if it's not major, you may just have a little swelling in your legs, or when you take your sock off, you might see a little bit of the sock imprint in your legs. Patients with extra weight have circulation issues, and so they're at risk for blood clotting. We give everybody blood thinner before surgery and after to try to minimize that. The #1 prevention for this is walking, and that's another reason why you got to go with that nurse who is there when you wake up from surgery. If you have an organ system that's not working so well, or in need of a tune-up, we're going to get that because stressing an organ with an operation of any kind can make it temporarily worse. So we'll get a checkup or a tune-up if we need to on your heart or kidneys if that applies to you. Specific to gastric bypass, there are risks including leak, which can happen in 1 in 500 patients. Bleeding can happen from these connections that we make. It's uncommon, but sometimes we have to do an operation to fix that or give a blood transfusion. Bleeding is rare. We're not worried about it more than we're worried about giving the blood thinner. We'd rather give you the blood thinner than not, because the clots are more scary to us than the bleeding. We operate on patients, Jehovah's Witness patients, so bleeding is uncommon. Bowel obstruction is a risk of any surgery, but particular to this operation where there's intestinal manipulation, there's risks of that. 4 to 7% of patients will need an operation for a bowel obstruction or a bowel issue or a hernia of some sort, all comers needing some kind of surgical intervention after gastric bypass surgery. Some patients can form an ulcer or a narrowing at the connection. Risks of the band, including slippage or shifting of the band. We place it in a specific position here and we need it to stay. If it moved, we'd have to put it back, and that's a surgery. The band could also erode into the stomach. Fortunately, this is only 1% incidence, and that means we put the band on the outside and it ends up on the inside. Well, that's no good for you. It won't work, and it also can cause infection, so we would have to remove your band if that happened. Fortunately, that's uncommon. Port flipping or turning is rare. We can almost always see it on our x-ray machine that I showed you. It's uncommon with the newer ports because they're wider and they're not quite as tall. Occasionally patients will have swallowing problems, and we check for that before surgery, but if you couldn't swallow very well after your band, that would require your band to be removed. Now fortunately, we've only seen that once or twice in the 8 years that we've been doing these things. Allergic reaction or immune system reaction is also possible with any surgery that involves an implant. We've not seen this, but it's reported, and so that's why it's on this list. Risks with the sleeve are similar to bypass, so you could have a leak or bleeding from this staple line, or a tight spot or a narrowing. These are very uncommon. We've not had any patients that have had, a significant bleeding from them or narrowing. Some patients do have some nausea after surgery, and they might have trouble because of swelling to stay hydrated, and they need some extra fluid. But almost always that resolves with time. Side effects. When you lose a lot of weight, your body tends to shut down some of the things that it feels aren't as important, like the hair and fingernail factory. So some patients will lose hair, and they'll grow it back later. You'll also have loose skin, depending on how much extra weight that you had and depending on how old you were at the time you had the surgery. If you've had a lot of extra weight for many years, you're less likely to have your skin recoil as a younger person would. Nutrient deficiencies are also possible if you're not taking your supplements. So that's a lot of stuff. General ballpark, 90% of people don't have any of those problems. All right, smooth sailing, things are good. 5 to 10% of people are going to have some problems or some transient issues that we deal with, and then they join up with the people who are back to normal, in the normal path. And then 1% of patients are going to have persistent issues. So that's important to know, because this is an elective operation in most cases, and we want you to know that there's always a small risk of ongoing issues. This is Jennifer, our dietitian, who you'll get to know well. She is in charge of making sure all the preoperative diets are done, but then also after surgery, making sure that you guys are optimized and doing the best that you can. She also has a blog on our website that you can read. After surgery, there's a few medicines we ask that you not take, including arthritis-type medicines like Advil, Aleve, Naproxen, Mobic. These will cause bleeding ulcers, and so we ask patients to not use them. Once you've lost a bunch of weight, it turns out you don't need these medicines usually. We also can give you some prescription alternatives if you do have some arthritis issues, and we work all the time with patients who need that stuff. Water pills, we usually stop them around the time of surgery to avoid dehydration. If you're a woman of childbearing potential, and you might think that you could never get pregnant because your periods are irregular or you've tried, But after you have this surgery, amongst other things that are good happening in your life with your weight and with regards to your medical problems, you'll become extremely fertile. Especially during the first year, I want you to use birth control and make sure that you do that. If you happen to get pregnant, though, don't hide. Just let us know, because we'll need to make some changes in your vitamin regimen, and also we'll want to work with your gynecologist to help you. Women can safely carry a baby after weight loss surgery. In fact, once you've lost your weight, you're going to do a better job of it. You're less risk for medical problems like gestational diabetes, preeclampsia, preterm labor, and women who are morbidly obese that have pregnancies are 4% chance higher of having a baby born with birth defects. So once you lose your weight, all that stuff goes away, and your risk levels for that are normal, okay? So getting you ready, we're going to ask you to do a few things. Number one is we're going to ask you to lose a little bit of weight, and you might be thinking, hey, that's my job. But I'm going to tell you why. It's important because if there's one thing that you could do to minimize your risks at the time of surgery, would you do it? I think so, and I'll explain that to you in just a minute. Become more active now, right? So start that exercise program, and if you're smoking, we need you to stop. Smoking increases your risks, all those risks we talked about times 10, okay? So it's important that you stop smoking. All right, so here's the deal with losing weight. This is a cartoon patient here who's thin, and here's her internal organs blown up. So the liver sits on top of the stomach. Now, as you recall from the drawings earlier, this is the area where we form the pouch for gastric bypass. This is where we place our band, and this is where we do the sleeve, all right? So this is where we need to work. Now the liver is on top of that. In our patients, everything's a little bit bigger, and so the liver usually covers up about half the stomach. Now, if you haven't lost any weight, the liver can be full of fat. Most people think when they gain weight that food goes from their mouth and it goes into their intestines and then it goes to their hips or their thighs or their love handles. Right? You've got a place where it goes. Well, the first place that it goes is your liver. Every drop of blood from your intestine before it goes anywhere else goes through the liver and drops off extra stuff, nutrients, fat. That fat makes your liver swell, right? If you start losing weight, the first place you lose weight from is your liver. So here's some pictures to prove what I'm talking about. This is a liver of a patient who did not lose weight before surgery, and this liver is large. This little piece of stomach is all you can see. We have to be working way up here, right? Now contrast that to this liver, which is nice and healthy. Look how much stomach you see there. And we can hold that liver up with a skinny stick, and we can work right in here, and everything's easy. Now, you want your operation to be the most boring, dull, routine, regular surgery that ever got done, right? You do not want to be an interesting case, okay? So how can you do that? Well, you can lose a little bit of weight. And we'll tell you what we need you to do. Most people, it's only 5, 10, 15 pounds. It's not very much, and we'll put you on a special diet. But it's really important, and that is why. Okay, word about insurance. Now, this is usually the thing that keeps us from going from these seats into the parking lot and doing it with spoons after we're done, okay? Insurance is going to ask you to do many things to qualify you for surgery, all right? They may ask you to go on a diet for 6 months. They will certainly ask that that diet is monitored by our practice and physician supervised. They may ask that you prove that you've been dealing with obesity for many years, right? So we will help you get through that process. But you will also be talking to your insurance company undoubtedly. And if they give you some information which seems contrary to what we're saying, run that by our girls because they know what the system is. Now you will hear them say, we're just waiting on Dr. Seeger to submit the paperwork. But what that means is we're just waiting on you to finish your 6-month diet. You know, they tell you things a little bit differently than they tell us. Support groups, very important part of our program. We meet in this room on the first Monday of every month at 6:30 p.m. and we invite you all to come. Even though you haven't had surgery, come to support group, meet our patients, ask them questions. It is open to you, right? One of us will be here. Next month that should be me since Dr. Duperior was here this past Monday. Fitness. Everybody should get a fitness evaluation and we feel strongly about that, so we're going to give it to you. When you come and see us in the office, we'll give you a free 3-month membership to this gym right across the hall. Included in that is a fitness evaluation. We bought those for you. We want you to take advantage of it. We want to break down the barriers that are standing between you and complete success. This facility is incredible. A lot of people have told us that they don't like to go to the gym because they feel like they're out of place, right? It doesn't feel comfortable to them. Well, this gym over here, everybody in it is in your boat, was in your boat. They're all looking towards the same goal, and it's very supportive, right? Every piece of equipment in there you can work with, right? There's nothing in there that wasn't built with our patients in mind. So everything is built to help our weight loss surgery patients, right? Take advantage of that, and we will give that to you, like I said, when you come and see us. So what's next? You can make an appointment if you haven't already. Many of you have, I know, but you can make an appointment right now to see us in the office. That is the next step. You need to come in and see us. Make sure that if you haven't already finished filling out that paperwork, that you do finish it for the ladies. The reason for that is when you come in to the office and see Dr. Dupere or myself, we're going to tell you, hey, look, this is what your insurance wants you to do. We're going to know all that so you can get that information that day. Right? If we don't have that information, then we have to go and get it and then look, and then you don't find out for another week or so what your insurance wants. Even if you don't think they cover it, let us figure that out for you. We'll call them and find out. Right? We'll do that for you. So make those appointments, come in and see us, and we'll get you started. If you happen to be a Medicare patient, Medicare has a specific set of requirements that they want patients to meet. So what we have done for you is we have our nurse who will look over your information. She may call and ask you a few questions, but she will make sure that you meet Medicare qualifications before you come in. That way you don't come in and find out, oh man, I don't meet qualifications. I just wasted, an hour coming to find that out. So we'll look at yours in advance, all right, for you. So you will be able to make that appointment once our nurse gives you a call and gives you the green light. Okay, so I'm very excited. I want to congratulate you all. I know that it takes a lot of courage, right, to come and hear one of these talks. It's a big moment. It's a big moment for you. I want to empower you to seek more information. Let us know if you have questions. Each and every one of you should have a card or something that has our emails on it. Myself and Dr. Dupere, you'll have our emails, our personal emails. If you walk out here tonight and you're at home and you're thinking of questions, hey, what did that guy say? It's Seeger, crazy guy. Email me, email him. You can call us, you can come and sit down with us. The seminars are online if you want to review any certain bit of it. The information is there. We're here to support you. We want to answer your questions, and we're looking forward to seeing you in the office.